the first thing I do is I know that around 50%, and it depends where you are. If I'm in my primary care clinic, maybe 50 or 60% of people have a directional preference or centralized when I do the McKenzie assessment. Now, I know what those people have as the source of their pain. Only discs do that. So I know they have discogenic pain, but I don't need to know that. I can just treat them on the basis of that, and the prognosis for that subgroup is actually really, really good. Okay, so what do I do with a person when I can cause the pain to move to the middle, or they get worse with flexion and better with extension, or the other way around, it doesn't matter, or they have a shift? What do? Well, I just do McKenzie, frankly, because it works. Okay, now the next thing is that what about the people who don't centralize? That's the other 50%, or 40%, or 60%, depending on where you are. Well, first of all, if they have a herniated disc, there's a bunch of options. First of all, you can just live with it, because we know that in 2 years, most people are going to get better, even if they're in severe pain right now. In fact, actually, the worse their sciatica is, and the more acute it is, and the more sudden the onset, the more likely that they'll be better in a year. All right, so a really bad case has a good prognosis. A person who has a slow onset of radicular pain, and they're not going to get better in 2 years. All right, so there's a whole bunch of options there for, depending on a particular pathoanatomic diagnosis, there are a number of different ways in which you can advise that person based upon their demographics, on their the way things have developed, and their imaging findings, and a whole bunch of things like that. So there's options for epidural injections, surgery, wait it out. I mean, these are people who are not centralizing mode. If they're centralizing, we know what to do. That's not a problem. People are non-centralizers. And there are things we can do with people with radicular pains.